Good afternoon, everyone, and welcome to the start of our 2023 curriculum for GI and hepatology. And we're really quite excited to start you on the liver program, which is going to cover what we think are core topics for you to understand and be able to interact with and be able to actually manage patients within your own practices. So I'm Wendy Spearman, head of the Division of Hepatology at Groote Hospital and University of Cape Town. And one of our fellows, Dr. Isneen Hilmy, will be presenting on chronic hepatitis B. This program is actually hosted by the Gastro Foundation in conjunction with the University of New Mexico. And we're really thankful to both the Gastro Foundation and Project ECHO from the University of New Mexico for really enabling these very important programs to be run and for us to be able to share knowledge throughout South Africa and Sub-Saharan Africa. So we're going to start with Dr. Hilmy starting to present. And I think hepatitis B really is, people often struggle with hepatitis B, how to interpret serology, how to actually decide on management, how to decide on follow-up. So we're going to, I think, break it up into sections. And once we've covered the sort of 5 phases of the chronic hepatitis B, we'll open that up to briefly to discussion and questions. So Isneen, over to you.
Thank you, Prof. Yeah, thank you for the introduction, Prof. And also I would like to thank the ECO platform and the Gastro Foundation for this opportunity to present. So today's my topic is hepatitis B. So hepatitis B was first discovered by Prof. Blomberg in 1965. It's like 58 years ago. Then he recognized it as Australia antigen because it was in the blood of the native Australian that reacted to antibody in the serum of an American hemophilic patient. However, we know that hepatitis B has been there even longer before because there was, interestingly, in the 16th century mummy, we had hepatitis B positivity. Today, according to the WHO in 2019, there are 296 million people living with chronic hepatitis. And the maximum number is in the Western Pacific region, around 116 million, which comprises of China, which has a population of 1.4 billion, as well as Mongolia, Australia, New Zealand, and many other countries. In Africa, we have around 82 million people living with hepatitis B as of 2019. So there are 1.5 million new infections every year, and in 2019, hepatitis B related mortality is close to 820,000. It's because of cirrhosis or hepatitis C, primary liver cancer. Looking at the African context, as I said, there's 82 million people with chronic hepatitis B. And HPV-related deaths in sub-Saharan Africa is estimated to be 87,000, over 87,000 every year. And there are numerous reports which show a high incidence of HCC in sub-Saharan Africa, and 80% of the HCC is because of the hepatitis B infection. So we have around approximately 2.5 million people living with hepatitis B in South Africa. And the HPSAG prevalence, it ranges from 3% to 2.5%. Hepatitis B vaccination was introduced in South Africa in April 1995. And overall seroprevalence of HPSAG is declining from 12.8% to 3% in some studies in the pre-HIV era. The WHO has a few strategies to eliminate viral hepatitis as a global health threat by 2020. So from 2015 to 2020, 30% reduction in new infections and 10% reduction in deaths And by the end of 2030, they aim 90% reduction and 65% reduction, 95% reduction of new infection and 65% reduction of deaths. So coming to the hepatitis B virome, this is called the DEN particle. As we know, the hepatitis B is a member of the Hepatinoviridate family, and it is there is a capsid which is enclosed by an envelope, and in the envelope we have different types of proteins, large, middle, and small molecular proteins. And there and 90% of the HPV DNA, it comprises of relaxed circular DNA with polymerase inside, and 10% has double-stranded linear DNA, and only 1% has a RNA. And this is the genomic structure of hepatitis B. I would not go into much detail, but the genes pre-S1, pre-S2, and S1, they code for the hepatitis B surface antigen, and P gene codes for polymerase. Co and pre-co together codes for hepatitis E antigen, and co codes for hepatitis C antigen. And the X gene, it codes for hepatitis X antigen, which has a role in hepatocellular carcinoma. So this is about the life cycle. As we know, the hepatitis B virus, it binds to the NTCP receptor, and then it enters into the hepatocytes, and where the capsid, nuclear capsid disassembly occurs, and the nuclear capsid is transported into the nucleus, where the genome is repaired to form covalently closed circular DNA or cccDNA. And this cccDNA serves as a template of viral RNAs, and is transcribed and then exported into the cytoplasm, where these RNAs are then translated into different viral proteins. Additionally, even the pregenomic RNA is packed by core protein with the polymerase, and the viral the viral genome is then replicated into through reverse transcription to form the negative strands and the positive strands. And the mature nuclear caspids, it can be either recycled to maintain the cccDNA, or it can be through it can be turned into the DAN particles and excreted through the ESRT pathway. So this is the natural history of chronic hepatitis B. So chronic hepatitis B, as we know, is a very dynamic process, and it reflects interaction between hepatitis B viral replication and the host immune response. So natural history is divided into 5 phases, taking into account the HBe antigen, hepatitis B viral DNA, and ALT levels. So the new nomenclature, it is based on the description of 2 main characteristics of chronicity, which is the infectivity and hepatitis. It is important to note that a single measurement of HBV DNA, hepatitis E antigen, or ALT may not classify the patient immediately into a single phase, because there are some gray zones which some of these patients fall into, and further serial testings might be needed. So hepatitis phase 1 is HBeAg positive chronic HBV infection. So this is previously termed as immune tolerant phase. So here you find that the HBeAg is quite present, and we get a very high HBV DNA of more than 200,000, and ALT is persistently normal, and there's none or very minimal necroinflammation or fibrosis. So this phase is prolonged in patients who are infected perinatally, and is associated with preserved HPV specific T cell function, at least until young adulthood. And as we know, there is very high HBV DNA, and there's high integration of HBV DNA and production of colonial hepatocytes expansion, which leads to hepatocarcinogenesis. And the rate of spontaneous HBeAg loss is very low in this phase. And then we have HBeAg positive chronic hepatitis. So the first one is HBV infection, where you have normal ALT, and then you have hepatitis where you have raised ALT. And here we do find the HBe antigen is positive, and HBe DNA is still high, but it's generally less than what was in phase 1, and it will be more than 20,000. And there's moderate to severe liver necroinflammation, hence the raised ALT, and it is accelerated. There's accelerated progression to fibrosis. And this may occur over several years, but the phase 1, several years of phase 1, but rapidly reaches phase 2 if patients are infected during adulthood. And the outcome of this phase is variable. So some patients, they can go into phase 3 or phase 4. In phase 3 means there's HBe negative, but the patient has HBV infection. And phase 4 is HBe negative chronic hepatitis B. So we previously phase 3, which is hepatitis E antigen negative Hep B infection, was previously termed as an inactive carrier. Here you have presence of anti-HBe or seroconversion, and HBV DNA is detected but low. So generally it's less than 2,000, and we have persistently normal ALT levels in this phase. Patients are very low risk for hepatocellular carcinoma, and HBsAg loss occurs at 1 to 3% per year. In HBe negative chronic hepatitis B, we have fluctuating levels of HBV DNA, so it will be more than 2,000. And we have persistent or fluctuating levels of ALT, and liver histology again shows necroinflammation and fibrosis. Most of these patients, they have HBV variants in the pre-co or basal co-promoter regions that actually impair or abolish the HBe expression. And then phase 4 is the occult infection. So this is characterized by negative HBsAg. So there's HBsAg loss and presence of anti-HBc, which will be positive. And there's normal ALT, and HBV DNA is usually detectable, but it's less than 200. And CCC DNA is frequently detected in the liver. And regarding the HCC risk, if the HBsAg loss was before the development of cirrhosis, then the hepatocellular carcinoma risk is low. However, if patient had already developed cirrhosis, then there is a need to surveil these patients for hepatocellular carcinoma. And it's important to note that occult in HBV infection, they can be reactivated after immunosuppressing a patient. So this is just a summary of what we just talked about. This is in the EASL guidelines. So the phase 1 is chronic HBV infection, and phase 1 and 2 is positive HBe antigen. In phase 3, 4, 5, you have a negative HBe antigen negative. And in chronic infections, you have normal ALT and minimal liver disease. And in hepatitis, chronic hepatitis, you find there's elevated ALT and moderate to severe liver disease in both HBeAg negative and HBeAg positive. And in resolved infection, it's occult infection. That's phase 5, where you have negative HBsAg and the low viral DNA and normal ALT and liver, no inflammatory response. So this just these curves, they just show the relative concentration of markers in a typical infection. And it's important to note that there are 2 window periods. And the first window period is pre-HBsAg window period, which is around 32 days. And then you have the HPV DNA and HPSAG DNA, which is 95 days and 63 days respectively. And after the fall of the HPS-AG, you find the anti-HPC, HPS antigen antibody formation. And between these two, in the second window period, it's around 10 days. And as you can see, most everything might be negative except for a total anti-HPC. And in afterwards, in phase 5, where patients have occult infection, once the anti-HPS level falls below 10, you can have a little bit of DNA which can be detected.
Thanks, Isneen. I think let's just open it up to discussion to make sure everybody's really happy with how these different phases evolve, and any questions that you want to ask at this point, because this is really essential to the understanding of chronic hepatitis B. If you understand the sort of natural history, this dynamic changes between the different phases, you really are able to understand when you treat, when you should monitor, and what the risk of liver cancer is. Any questions so far? You're all happy. If you feel more comfortable, you can also put it in the chat. But really, this is extremely important. So you need to think of this as a story, and particularly, so if you acquire hepatitis B as an adult, then you're much more likely to be able to clear the hepatitis B. But remember, in sub-Saharan Africa, including South Africa, the majority of patients acquire it either in childhood or from mother to child. And so they are acquired at the point in time where they established the immune system in terms of the B-cell immunity, T-cell immunity is not very well established. So and remember that the E antigen in the mother is highly tolerogenic. So in the fetus, you have basically this tolerogenic E antigen, and so they don't mount a response. The E antigen positive, very high HPV DNA levels. And then in your 20s to 30s, basically your cellular immune system starts waking up. You now have a targeted response cellular immune attack on those infected hepatocytes. And then it really depends on how effective that is. If it's highly effective, you will clear E antigen, become E antibody positive, DNA levels come right down, and you will enter that immune control or E antigen negative chronic infection. But the problem is that often you have numerous attempts to clear it. And with each attempt to clear that E antigen, you lead to damage. So that's really important to actually recognize that E antigen positive chronic hepatitis, because those patients need infection. And then when you enter that immune control phase where you are surface antigen positive, E antigen negative, normal ALT, the degree of immune control is very variable. Okay, so some have excellent immune control. So they're less than 500, the DNA levels. Others, the immune control is not so great. So it's running, you might run a DNA like 1500, then it goes to 19, then it bumps above 2000, comes down. So you can imagine those who have extremely good control, under 500, will probably remain in that immune control phase, or E antigen negative chronic hepatitis infection. But those who don't have good control and they're above 1500 and they bounce over to 2010 and then back down again, those are the ones that are actually developing these pre-core and basal core promoter mutants. And once again, as that DNA starts rising, your cellular immune system starts reacting again. And once again, you now have an immune attack and you have active neck inflammation. And because it's further down the natural history, these patients often have quite significant fibrosis and they can decompensate quite quickly. So I think if you think about this as a dynamic story and thinking it particularly where we actually practice actually being acquired in childhood. Any questions before we move on? Okay, so you can go on.
Okay. So we'll move on to the initial assessment of the patient. So it's very important that we take a complete history from the patient. So we have to ask about any acute hepatitis, but acute hepatitis infection history on in a patient with chronic hepatitis B is often lacking. But we ask about malaise, nausea, vomiting, or serum sickness like prodromes like fever, arthralgia, or rash, which could be the maculopapular or urticaria. And sometimes patients do present with acute liver failure, but it's very rare. And usually it happens within a month or 4 weeks after developing symptoms. And it's also important to note what is the mode of transmission, like whether it's a needle sharing or due to a blood transfusion, or it's through sexual partners. And it's also important to note what are the family contact history and and history of cirrhosis in the family or hepatocellular carcinoma in the family. And then in physical examination, usually in chronic hepatitis B, you might not, it could be completely normal, but it's important to look for hepatosplenomegaly or any features of decompensation of the liver disease, especially like spider navies or jaundice, ascites, peripheral edema, and even the other extra hepatic manifestations of chronic hepatitis B, such as arthritis, dermatitis, polyarthritis nodosa, glomerulonephritis, and cryoglobulinemia. It's important to look for these things in physical examination. And then regarding the assessment of liver disease activity, we look at the biochemical parameters, especially the liver function test, AST, ALT, the gamma GTs, ALP, bilirubin, and albumin, and of course the full blood count, and never forget the PT, prothrombin time. And we also look at the HBe antigen and anti-HBe, so that we can essentially determine which phase of chronic HBV the patient is in. And even HBV DNA serum levels are also very important. And it is not necessary that we do HBV genotyping in the initial assessment. And anti-HAV should be performed, and patients with negative anti-HAV should be vaccinated against hepatitis A virus. And all patients should get ultrasound of the abdomen during the initial phase. So these are just the extrahepatic manifestations which I just talked about. So in acute hepatitis B, you can have those systemic manifestations and polyarthritis, arthralgias. And in chronic hepatitis, you can have reduced quality of life, uveitis, non-Hodgkin's lymphoma, and other skin manifestations, and MPGN and IgA nephropathy can be there. And regarding the liver biopsy is the gold standard to determine the liver fibrosis and the inflammation in the liver. And we also have some non-invasive tests or NITs which can be used to determine the severity of or the disease activity. So the non-invasive tests, they include like simple scores like EPRI or FIB4 scores, or there are commercially available blood markers like FibroTest. So basically the EPRI score, it just needs the AST levels and the platelet count, which will give the EPRI score. And transient elastography or fibroscan, which offers the highest diagnostic accuracy for detection of cirrhosis versus other non-invasive tests. So for diagnosis of cirrhosis, fibroscan has the best sensitivity of around 85%. And even the EPRI low cutoff has a 65%, and a high cutoff will have a 35% sensitivity. They do have EPRI and fibroscan do have similar specificities of 87 and 89%. And to diagnose moderate fibrosis in a METAVIR score of F2, you can use the sensitivity is similar. It's like 78% for fibroscan, and for a low cutoff of EPRI, it's 76%. So WHO recommends the use of EPRI more than 2 or liver stiffness more than 12.5, which will diagnose cirrhosis. And if EPRI is more than 1.5 and a liver stiffness of more than 7 on a fibroscan, it means there's significant fibrosis. In EASL, they don't talk about EPRI score, but there's, as we know, There is the confounder for a FibroScan is actually inflammation of the liver. So if there's normal ALT levels and the stiffness is more than 9, it means the patient has severe fibrosis or cirrhosis. And if there's raised ALT, but it is less than 5 times the upper normal limit, then we can take a liver stiffness cutoff of more than 12 as to note that there's severe fibrosis or cirrhosis. So all the first degree relatives and sexual partners, they have to be tested for hepatitis B. So we have to do the HBsAg, anti-HBC, and HBs and anti-HBC. And if they are negative, we have to vaccinate. And it's also important to rule out other causes like alcoholic hepatitis, autoimmune or metabolic liver disease, and other causes for chronic liver disease as well. And it's also important to include other co-infections like hepatitis D virus or hepatitis C and hepatitis HIV. So this is just to reinforce on the users. So HBsAg, it's a marker of infection, and it's the first surgical marker to appear. And if it's present for more than 6 months, it means it's chronic. HBeAg is marker for acute liver application, and it's absent in some viral mutations. And anti-HBs, it means the patient has recovery or has developed immunity, and it can be detected even after vaccination. And anti-HBe and seroconversion, so it's important to know which phase the patient is in. And for occult infections, we use anti-HBC total antibody to detect it. So this is a nice interpretation results from ASLD. So if you have a hepatitis HBsAg positive and anti-HBC positive and anti-HBs negative, that means patient has chronic hepatitis, and you don't need to vaccinate these patients. However, if there's HBsAg loss and you have anti-HBC and anti-HBs positive, that means there's a past infection which has resolved. And the same scenario with a negative anti-HBs, it means either the patient has resolved infection or patient has, it could be a false positive test. So in these patients, if the patients need to be vaccinated, if they're from high endemic regions, I guess we can vaccinate these patients in our setting. And if you have only anti-HBs positivity, that means patient is immune. And if everything is negative, that means patient is not infected and non-immune. So we need to vaccinate these patients. And coming to treatment, so the main goals of our treatment is actually to improve the survival and also improve quality of life by basically preventing disease progression. And also this will reduce the development of HCC as well. And additional goals are to prevent mother-to-child transmission and hepatitis B reactivation, and prevent and treat HPV-related extrahepatic manifestation. And also, it could be a goal to a regression of fibrosis and cirrhosis from a patient who has established advanced fibrosis or cirrhosis, and in patients with HCC to suppress viral HPV replication and to reduce HCC recurrence. And also in acute hepatitis, we can use it to prevent acute liver failure and improve quality of life by shortening the duration of the symptoms and also lowering the chronicity. So these are basically the endpoints of therapy given in EASL. So it's induction of long-term suppression of HPV DNA levels and induction of HBeAg loss with or without HB seroconversion, and also biochemical response, which is defined as ALT normalization. And the optimal endpoint would be a HBsAg loss with or without seroconversion. So these are the indications for therapy. So any patient who has cirrhosis or who develop hepatocellular carcinoma, or any patient who has a family history of HCC and who has extra hepatic manifestations, they need to they can be treated for hepatitis B. And if there is no cirrhosis, if HPV DNA is more than 2000 with raised ALT with moderate necroinflammation, we can start treatment. Even if ALT is normal, but the HPV DNA is more than 2000 and with moderate necroinflammation, we can start the treatment. And if HPV DNA is more than 2000 with the ALT and AST more than 2 times upper limit of normal, then we can start treatment irrespective of the degree of necroinflammation. And in HBeAg positive chronic HPV infection, especially if the patient is above 30 years, regardless of liver fibrosis, they can be treated. And in ASLD guidelines, they say more than 40 years, regardless of fibrosis. So if the patient is currently not on treatment, so that means the patient has no indication for treatment with normal ALT levels. However, we have to monitor them regularly, and this monitoring can be done with ALT, DNA levels, and non-invasive testing. So the follow-up intervals are if patient is HBeAg positive and less than 30 years, we can follow the patient up every 3 to 6 monthly. And if the patient is HBeAg negative and a DNA level of less than 200, we can follow them up every 6 to 12 monthly. However, if the DNA level is more than 200 and HBeAg is negative, we can follow them up initial first year every 3 months and then following that every 6 months. So this is a algorithm for management of HPV infection. This is the EASL guideline. So if you have a suspected HPV infection, then we have to see whether the HPSAg is positive or negative. And then we also look at the HPC, whether it's positive or negative. So this is basically the occult HPV infection, and this is the HPSAg positive. So if HPSAg is positive, then we look for whether the patient has chronic HPV infection. If there's no signs of chronic hepatitis, we can keep the patients in under monitoring. And with monitoring, we basically monitor the HPSAg, HBeAg, HB viral DNA, ALT, and liver fibrosis, and liver fibrosis assessment. And then if there's high risk of HCC, and if there's a risk of HPV reactivation or extrahepatic manifestations, then we can start, or risk of HPV transmission, then we can start the patient on treatment. Otherwise, we can go back to monitoring. And during monitoring, if patient develops chronic hepatitis with cirrhosis, with or without cirrhosis, then it's again an indication for treatment. And in patients with HPSAg negative occult HPV infection, there's no need to refer to any specialist follow-up, but we have to be careful because in cases of immunosuppression, we might need prophylactic oral antivirals. So this is the ASLT guideline. So it's a bit more complex than the EASL guidelines. So just to mention, basically the difference is they look at the HBeAg positive and HBeAg negative patients. And even if HBeAg is positive, if you have ALT of more than 2 times normal, then it's indication for treatment. And if HBeAg is negative, and if you still have high ALT levels and HPV DNA of more than 2000, that's also an indication for treatment. And the difference between the EASL guidelines is one, they tell to use in EASL, they use the upper limit of normal, ALT upper limit of normal, but here that is less than 40. And in ASLD, they say for males, it's 29 to 33, and females, it's 19 to 25. So coming to treatment strategies, so we can either choose. So we have, these are the different timelines which tells us like interferon was the first to be approved for treatment, and then lamivudine, edifovir, and we have either interferon or NAs to treat hepatitis B. So interferon, now we use the pegylated interferon because pegylated interferon had improved pharmacokinetic effects and less demanding infusion schedule. So the mechanism of action is basically it works by immunomodulation, and the nucleic acid analogs, they can be divided into low barrier of resistance or high barrier of resistance. So basically the lamivudine, edifovir, and Telbivudine, they have a very low barrier for resistance, and tenofovir, TAF, TDF, and entecavir, they have a high barrier of resistance. So mechanism of action is NS, they resemble the naturally occurring nucleosides, so they cause DNA chain termination. And when we look at lamivudine, it's low cost, and then the other NAs, and we've been using it for quite a while, and it has a good safety profile. It's rapid and potent viral suppression. However, the problem is low barrier for resistance. So almost more than 50% of patients after 5 years of treatment develop resistance. And edifovir, it was approved in 2002. It's a potent antiviral, and the problem again is the resistance. In 5 years, you have 29% of resistance, and also renal toxicity is a problem with edifovir. And regarding entecavir, it was approved in 2005, and we use the 0.5 milligrams daily, and if it's cirrhotic patients, it's used 1 milligram per day. And when we compare with lamivudine, it has superior virological response, histological improvement, and ALT reduction. However, they have similar seroconversion rates. And there is a high barrier of resistance to entecavir. So it's just 1 to 2% in after treatment with for 6 years. And tenofovir, they have no resistance so far, and it's more potent antiviral activity than edifovir, but less so than lamivudine. And it's tenofovir is effective in suppressing the wild type HPV, and also if the patient has a lamivudine resistance, we can use tenofovir. The problem with tenofovir is obviously nephrotoxicity and bone-related issues. Like I said, there's no resistance to tenofovir till date. So the advantages of these drugs are that they are like long-term antiviral efficacy and favorable safety profile, and they can be in certain situations the only treatment, like in patients with decompensated cirrhosis, so liver transplantation, extrahepatic manifestations, acute hepatitis B, severe chronic HBV infection, and HBV prevention for immunosuppression. And regarding the interferons, so they can be used to induce long-term immunological control with finite duration. The disadvantages are they are highly variable to response to treatment, and they have unfavorable safety profile. So patients can develop flu-like illness, thyroid dysfunction, fatigue, or myelosuppression. So this is just to summarize the difference between tenofovir TDF and TAF. So TDF, they have 25% bioavailability compared to TAF, and more higher concentrations are needed for TDF compared to TAF. There's there's decreased bone mineral density and renal toxicity associated with TDF, and distribution is it's in a wide range of tissues, whereas TF it's selective to white blood cells and hepatocytes. And when do we select entecavir or TF over TDF? So if patients are more than 60 years of age, or if they have chronic steroid use or other medication that can worsen the bone densities, or history of fragility, fracture, or osteoporosis, and renal alterations. Yeah. So in those patients, we can select entecavir or TF over TDF. So long-term administration of so this is a prevention of resistance should rely on the use of first-line NAs with high barrier of resistance. So the EASL, they actually recommend regimens with entecavir, TDF, and TF as monotherapies, and they do not actually recommend lamivudine, ADV, and TBV for treatment for chronic hepatitis B. So these are the definition of response. So there's a virological response means on NA therapy, the HPV DNA less than 10. If patient is on pegylated interferon, the HPV DNA of less than 2000. Primary non-response would be when you have less than 1 log decrease in HPV DNA after 3 months of treatment. And partial response would be if the HPV DNA is decreased by more than 1%, but still detectable after 12 months, 1 year of consolidation therapy. And virological response off treatment. So this means if you have sustained response that is HPV DNA less than 1000 for more than 12 months after stopping the therapy. And serological response is your HBeAg loss and development and seroconversion, or HBsAg loss and development of anti-HBs. And biochemical response is ALT normalization, and histological response means decrease in necroinflammatory activity without worsening of fibrosis compared to the pre-treatment histological findings. And regarding the management of NA failure, treatment should be adapted as soon as biological failure is under NA is confirmed. So if a patient was found to be lamivudine, TBV, or entecavir resistant, then you can switch to TDF. If adufovir resistant, then we have to see if the patients are lamivudine naive. If they are lamivudine naive, we can switch to entecavir or TDF. If lamivudine resistant, then we can drop the entecavir and treat with TDF or TAF. And if TDF or TAF resistance, then we can either give switch to entecavir if it is lam naive, and if lam resistant, then we can add entecavir to the TDF treatment. In multi-drug resistance, we can either switch to entecavir plus tenofovir, either TDF or TAF combination. So regarding stopping NS, there's so it's very usually long-term therapy with NS required, and HPV eradication is usually not achieved. So NA should be discontinued after you confirm that the HBsAg loss, and with or without anti-HBs seroconversion. So HBsAg loss is very important. And NS can be discontinued in non-cirrhotic patients who have seroconverted from HBe antigen to anti-HBe with undetectable HPV DNA, and who had completed at least 12 months of the consolidation therapy. And these patients have to be closely monitored. You can discontinue NS in selected non-cirrhotic HBe negative patients who achieve long-term, that is more than 3 years of virological suppression. However, we should guarantee that these patients can be monitored closely. So regarding special considerations, so HBV and cirrhosis, the goal is to complete viral suppression in the shortest possible time. So, and this will achieve clinical recompensation and also to avoid liver transplantation. And the treatment with NS as early as possible. You can use either entecavir or TDF. Entecavir, like I said, 1 milligram once daily, not 0.5 if patient has compensated cirrhosis. And so pegylated interferon is contraindicated in these patients, and patients should be referred for liver transplantation if patient has decompensated cirrhosis with HBV. And long-term patients should be on lifelong treatment. There's no stopping treatment in patients with decompensated cirrhosis. And there's very high risk of developing HCC. In HPV and HIV co-infection, so it is recommended to start ART, which has TDF or TAF in it. And irrespective of the CD4 count, the patients should be on treatment because there's a high risk of fibrosis and progression to liver cirrhosis or HCC. And we should always avoid stopping the TDF or TAF containing ARTs because there's in patients who stop it, their patients can have severe hepatitis flare, or patient can decompensate and reactivate hepatitis. And it's important to monitor the renal functions, liver functions, and bone mineral densities closely. And as we know, the HIV, HPV mortality is 2 times greater than HIV and HCV mortality. And especially in patients with lower CD4 count, less than 200, it's 16 times greater than those with higher CD4 counts of 350. And there's also increased risk of perinatal HPV infection in these patients. And regarding HPV infection, it accelerates progression of liver disease and hepatocellular carcinoma. And HCV usually has the greatest contribution to the liver disease. And SVR rates in mono-infected versus co-infected patients are comparable. So we treat the hepatitis B prior to initiating HCV treatment, and all those that qualify for hepatitis B treatment initiate it first. And if chronic hepatitis B and do not qualify, then consider prophylaxis until 12 weeks post the DAA therapy. In occult HPV hepatitis, we have to monitor closely and investigate for reactivation of raised ALT. And regarding prevention of mother-to-child transmission, so it's quite common, and co-infection with HIV, basically it increases the risk of transmission by 2.5 times. And annually, 1% of the newborns are affected with HPV. Currently, there are no formal programs for HPV screening in pregnancy. However, and the WHO recommends screening if the prevalence is more than 2%. So all pregnant women, they should be screened for hepatitis B vaccine in the first trimester. And those who are not vaccinated should receive the vaccine. And if they are found to be hepatitis B positive, then we need to do the further testing, counseling, and the medical management. And we also need to do the basic contact tracing and all the routine things which we'll do. And if immune tolerant or immune control phase, means if the patient is HBeAg positive with hepatitis infection or with chronic hepatitis, they do not require treatment, but you need to consider treatment if there's transmission, especially if the HPV viral load is more than 200,000. So hepatitis B immunoglobulin and birth dose vaccine. within 24 hours of delivery it would prevent the transmission by 85 to 90%. So we should consider treatment with TDF 300 milligrams for all patients with chronic hepatitis B in the 3rd trimester, and it should be continued 12 weeks postpartum. So regarding patients who are undergoing therapy for immunosuppression, so we can risk stratify these patients into basically 3 groups, whether they are high risk of activation more than 10%, or are there like 1 to 10% risk that is moderate, or low, which is less than 1%. So high risk patients are those patients who undergo like a B cell depletion agent like rituximab or ustekinumab, or very high doses of steroids. These are patients with high risk of reactivation. And even the anti-TNFs like infliximab, adalimumab, golimumab, they are at high risk. Patients who receive these will be at high risk of reactivation. And patients who have moderate risk are those with, say, systemic chemotherapies and less potent anti-TNF like Entacept, and even other anti-integrins like vedolizumab or cyclosporine, moderate doses of steroids. They all can be considered as moderate risk. Low risks are those patients who are on low dose short-term steroids, so azathioprine or methotrexate. And all patients, they need to be screened with hepatitis HBsAg, anti-HBs, and anti-HBc prior to starting immunosuppression. And it's recommended to vaccinate all the seronegative patients. And if the patient is higher doses of vaccine may be required to achieve anti-HBs response in immunocompromised patients. And all these patients are to be started on a potent NA therapy or as prophylaxis. So if the patient is HBsAg positive, then patients with chronic hepatitis B should be treated with entecavir, TDF or TF, similar to immunocompetent patients, and patients monitoring and stopping rules are the same. And prophylactic lamivudine, it reduces risk of HPV reactivation and morbidity and mortality. So we continue the prophylaxis for at least 12 months after cessation of immunosuppression. And if it was with rituximab, then at least 18 months. And after discontinue prophylaxis only if the underlying disease is under remission. Otherwise, we continue with the prophylaxis. And liver functions and HBV DNA should be monitored every 3 to 6 monthly during prophylaxis, and for at least 12 months after the NA withdrawal. There's large proportion of patients, they develop HPV reactivation after stopping the nucleotide agonists, analogs. And in patients who are HBsAg negative but anti-HPC positive, always test for the HPV DNA before starting immunosuppression. And if patient is viremic, then patient need to be treated as just as you would treat a HBsAg positive patients. And in patients who would be at high risk of reactivation, then prophylaxis should be continued for at least 18 months after stopping. And we monitor these patients at least 12 months after prophylaxis is withdrawn. And lamivudine may be used safely, but few cases of HPV exacerbation has been reported due to lamivudine resistance. Prophylaxis we should consider with the entecavir or tenofovir regimens. In moderate risk or low risk patients, rather than a prophylactic dose, we go for a preemptive therapy, meaning we look for the main virological events is either the patient seroconverts to HBsAg positive, or patient has detection of HBV DNA. So this means patient can have hepatitis flare, and it could be life-threatening. So we don't wait for the ALT, AST to come up. Rather, we start treatment early on, and we monitor. So in these patients also, the patient they should be monitored with HBsAg, HBsAg and viral DNA every 3 months. Regarding the management of extrahepatic manifestations, they respond well to NA therapy, and pegylated interferon is not recommended because some of the extrahepatic manifestations, some immune mediated, it can actually worsen, and we should avoid. And plasmapheresis, corticosteroids, and potential other immunosuppressive drugs can be used in addition to the NA therapy. So this is just, this slide is quite busy slide, but it just shows you different newer upcoming therapy, the novel treatments like entry inhibitors. So we have the NTCP binders, which basically prevents the HPV infection from entering the cells. So the clinical trials are in phase 3 trials right now. And then we also have the cyclophilin inhibitors. So these are these are host proteins that assist with viral entry, and they're actually in phase 1 trial. And cyclosporin A is similar activity to cyclophilin inhibitors. The only thing is cyclosporin A is immunosuppressive. And then we have the RNA interferase like siRNA, which is a small interfering RNA, and it causes in vitro. They're currently in the phase 2 clinical trials. And then we have the antisense oligonucleotides. So these are small pieces of RNA which actually binds to a specific molecule of the RNA blocking protein. So they're also currently in phase 1 or 2 clinical trials. And then we also have the co-protein modulators like CPAM. So they are non-nucleoside small molecules that actually inhibit the pre-genomic RNA encapsulation and alters the capsid formation. So these are all oral agents, and most of them, they're in the phase 2 trials. And you also have other secretion inhibitors like nucleic acid polymerase, or S-antigen transport inhibitor, oligonucleotide polymerases, and FRX agonists, which basically reduces the secretion of the viral particles into the blood. Thank you.
Thanks, Isneen, for a really excellent overview. We've got some quite important questions in the chat from Nakukunda. In the natural history of hepatitis B, do immunocompromised individuals mount a less immune response to hepatitis B, meaning less damage? So that's really quite an important question. So if you're immunocompromised, the hepatitis B DNA level tends to rise much more rapidly to much higher levels. And as you know, the hepatitis B itself is not usually intrinsically cytotoxic to the hepatocytes. It's your immune response to it, except in certain situations. So if you are profoundly immunosuppressed, so if we look at the liver transplantation prior to access to the antivirals, you would take your hepatitis B DNA replication within its first sort of 3 months, more than 170 million. And what would then happen is that the hepatocyte itself would actually shut down. So you have this massive deposition of surface antigen within the hepatocyte and responsive fibrosis. So you get this cholestatic fibrosing hepatitis with basically mitochondrial shutdown. And that's been seen also in patients who are HIV hepatitis B co-infected who become non-adherent. So the hepatitis B is much more robust. It virally escapes long before the HIV, and you can actually have this fulminant fibrosing cholestatic hepatitis. But that's relatively uncommon. So what we normally see in patients who are immunocompromised for whatever reason, including immunosuppression, is that you see this increase in the DNA levels, and there's repeated attempts to actually clear the virus. And with each attempt, which is unsuccessful, they're actually left with scarring. So in fact, they tend to have more scarring over a prolonged period of time. Does that answer your question? Are you happy with that explanation? So I think importantly, and the other important thing, particularly if you're HIV infected of a low CD4 count, you often have a dysregulated cellular immune response, and these patients are actually more likely to get fulminant liver failure if you're HIV positive and then acquire hepatitis B on top of that. That's really quite an important question that you asked. In resource-limited settings, what would be the first hepatitis serology test to perform? E antigen or surface antigen? I mean, maybe does somebody want to address that? Give some thoughts. Would you do surface antigen or E antigen? You've got limited resources. What would you do? Isneen, what would you do?
I would do a HBS AG.
Yeah. So so you've got a surface antigen. Okay. I think probably what you want to, so surface antigen, really you have to have that to define whether you are infected with hepatitis B. Your E antigen then puts you into the different phases. The DNA level tells you how actively your replication, and the ALT will tell you, do you have active necroinflammation? So one of the problems is actually the access to measuring hepatitis B DNA levels, which is really quite expensive. I mean, it's over 1,500 Rand. So if you don't have access to the DNA, you have access to an E antigen, you then have to decide, do you have hepatitis or do you only have infection? And that's where your ALT will come into it. Okay. But I think we need to, for hepatitis B, I mean, and this is worldwide, globally a problem. We worry about doing a hepatitis B DNA level, but we have no problems doing an HIV level molecular diagnostics regularly. So I think we have to move away where we find it's acceptable that we cannot get access to hepatitis B DNA level when we can easily get HIV viral loads. So surface antigen, definitely. E antigen will help you decide whether you are E antigen positive, E antigen negative, but remember, being E antigen negative doesn't equate to not actively replicating. Then the other question was the treatment of a patient with a family history of hepatitis B related HCC, as well as healthcare providers. So that's a very important thing. So if there's any history within the family of liver cancer or aggressive liver disease, you treat the individual regardless of what their E antigen status is, their DNA status is, their ALT. So anybody with a history, family history of HCC or aggressive liver disease, you treat regardless. The question of healthcare providers, that is an interesting question. So in fact, we don't have any legal requirements that you have to suppress your DNA level to less than 200. If you look in the EU, if you look in the UK and the States, it's recommended that healthcare providers are treated and that they are virally suppressed so that they decrease the risk of actually transmission. And that's obviously very important if you in a discipline that's going to have more high risk, so surgical specialty and ICU and anesthetists. Our recommendations from Liver Clinic is that you have a healthcare provider, you should be treated and be virally suppressed. And that would apply to all forms of healthcare providers. The same thing actually applies in situations like somebody who's living in a care home. And that's also an indication to treat and virally suppress to prevent the risk of ongoing transmission. Any questions on that? And then quite an important question, is the tenofovir dose the same in both compensated and decompensated hepatitis B? Exactly the same dosage. All that you need to be looking at, particularly the decompensated, is what is their renal function. So you might have to look at considering for TAF rather than tenofovir. So just before, if there are any other questions, either just ask or put it in the chat, but just to make a few comments that I noted going whilst Isneen was actually presenting. I think the important thing is when we take a history, so we always ask about risk factors for viral hepatitis. It's probably more relevant for hepatitis C. Remembering living in Africa is a risk factor for hepatitis B, and then you really look and see how old is the patient, and if wherever they're living, were they born pre or post introduction of hepatitis B vaccination into the EPI schedule. The symptoms of chronic liver disease, and I think this is really one of the problems why chronic liver disease is underestimated, why pediatricians often don't think that hepatitis B is a problem, because the problem presents in adulthood. And unfortunately, these patients are completely asymptomatic until they decompensate, or more concerningly, present with multifocal HCC. And so those of you at Critiskea, I mean, at the moment, we are regularly on a weekly basis being referred young individuals with multifocal HCC, which in fact, they are inoperable. You can give palliative care in the form of tests, but really we're not making any difference. So I think, obviously, we always take a detailed history, but one of the problems is these patients are completely asymptomatic, and they really don't tend to have peripheral stigmata of chronic liver disease. Remember, that's only present in about 30% of cases, and you have very florid stigmata such as palmarothema, the Dupuytren's, the spider neva. You need to think about alcohol. So unfortunately, often on exam, there's really nothing to find on examination. The other thing that I wanted to just raise is the non-invasive tests. So obviously, if we look at the burden of liver disease due to hepatitis B, liver biopsy is really not feasible and not really indicated. So we do look at non-invasive tests. And as Isneen quite rightly said, the WHO recommended the APRI score greater than or equal to 2, being suggestive of cirrhosis. And as we have seen, anybody with cirrhosis must be treated. The problem is none of that was never validated in Africa. And so the study, a very good study coming from Ethiopia, showed if they actually applied the APRI score greater than 2, 50% of individuals with cirrhosis did not meet the criteria and were not treated. So it really had a major failing. So what we've done, a group of gastroenterologists, hepatologists across sub-Saharan Africa from about 8 countries, 12 different centers, looking at a group of 4,000 patients with chronic hepatitis B and correlating the FibroScan and the APRI score. And it showed that the APRI score had to be actually rule in cirrhosis. The APRI score was 0.67, so significantly lower than that greater than 2. And as a result of that, probably the new WHO guidelines, which will hopefully be coming out by the end of this year, will have actually adjusted that APRI score. So I think always remember, many of these scoring systems have not been validated in Africa. And I think you need to also know, when you're looking at a non-invasive test, what does it mean? So an APRI score, you've got the platelets and the AST. Does anybody want to tell me what, why is AST and platelets? Why do they actually tell you about severity of liver disease? Does anybody want to try and give?
Platelet may be due to the splenic sequestration in cases you have cirrhosis.
Absolutely. So evidence of full hypertension and hypersplenism. And why is the AST important? Why is that an indication of fibrosis? Anybody? So remember yeah, go for it.
I was just going to say, is it anything to do with mitochondrial damage? Or
yes, absolutely. So your AST comes from your mitochondria and your cytosol. Okay, so the sicker your hepatocyte, the AST is going to be higher than the ALT. So when you follow these patients, usually the ALT is higher than AST, but as those hepatocytes become sicker, start developing fibrosis, you see that AST rising is more than the ALT, but there's never going to be a reverse 2-to-1 ratio. So I think when we're looking at non-invasive tests, we need to know why we're looking at it and what are the individual figures, and just remember that they not necessarily have been validated in Africa. I think there's another question here. I've had one one flexibility with a 32-year-old patient in Nigeria, DNA count of 1800, while the FibroScan showed F2. So I started the patient on TDF. Absolutely. So very, very important. Remember, guidance documents are guidance documents. So if you've got a, you don't mention whether he's E antigen negative. I presume he's E antigen negative because he's got a relatively low viral load. Okay. But if you think about it, remember I spoke to you about in terms of how good is this immune control? If you've got a viral load of 1800, it's nearly 2000. And now you've already got evidence of FibroScan showing F2 fibrosis. This patient absolutely must be treated. It doesn't really matter what the ALT is. And so that is where Isneen mentioned that you actually monitor those patients more frequently in that first year. I think every 3 months in resource limited settings is probably going to be difficult, but definitely every 4 months for that first year, and then every 6 months. But I think it is important to look at a combination of factors, not just a single factor. What was the other thing? Any other questions whilst I? Oh yes, I think isn't it? You mentioned treating acute hepatitis B to prevent chronicity. Do you want to maybe think about that statement, and or somebody else? What do you think about that? Treating acute hepatitis B. Are there indications for treating acute hepatitis B, and what would they be?
Wendy, I was also going to ask him that. Hello, everybody. Thanks, Isneen, for that presentation. I was going to ask him, in which setting would you treat acute Hep B, and then what drug would you choose and why? Just as a follow-up on your question. Thanks.
Good. Anybody who's been through liver, I think must actually try and give me a... Cecilia, can I call on you? Otherwise, I'm doing all the talking here. Deathly silence here. All right, so.
I can say something.
Okay.
So, I mean, indications would be anyone with acute liver failure, so developing a coagulopathy, or anyone with a encephalopathy. And I would use lamivudine because they obviously can be quite sick then in the acute phase, and you worry about renal impairment, particularly if they've quite jaundiced and you've got a lot of bilirubin damaging the renal tubular cells. The risk is obviously not obviously. So I think the risk is then that the way the hepatitis B is, your immune system is what gets rid of the hepatitis B. And obviously, if you dampen that down by giving them medication, you have a less virulent immune response and you have a higher risk of developing chronic Hep B. I don't know.
Yeah, no, absolutely. So if you've got an uncomplicated acute hepatitis B and you're under the age of 40, you should not treat, okay? Because remember, as your DNA level rises, your cellular immune system starts activating and you start targeting those infected hepatocytes and you destroy them and you clear the virus. Now, if you bring in an antiviral, you will rapidly decrease that DNA level and you switch off your cellular immunity. So you actually increase the risk of chronicity. But correctly, if you've got somebody who is actually having fulminant liver failure, you must treat, okay? And lamivudine would be the treatment of choice because lamivudine actually brings down that viral load much more rapidly than tenofovir. Tenofovir can actually take a year in order to have hepatitis B viral load completely suppressed. So the lamivudine brings it down very rapidly and switches off that cellular immunity. So we would do it for acute liver failure. We also do it for patients sort of over the age of 40 who you see that bilirubin rising, you see the transaminase just not settling, INR is sort of going 1.5, 1.8, 1.9. Those are individuals that probably are not going to clear it. And you'd also start them on a lamivudine, initially stabilize, and then you'd bring in tenofovir. So I think one needs to remember in terms of lamivudine, absolutely resistance is a problem, but you're not going to run into resistance in that first 6 months. And it's really very useful in bringing down that viral load very, very rapidly. And then the other thing is, I think it's important to remember that for pegylated interferon, In fact, that really, there's very small clinical profile patient who actually meets those criteria. And in fact, access to pegylated interferon is actually quite difficult nowadays. In fact, it's been discontinued here in South Africa and in many countries across Africa. And one of the problems is that you need to have a short duration of chronic hepatitis B. You need a young individual, you need a low viral load, less than 1 million, and you need to have evidence of active necroinflammation. So you need a liver biopsy showing active necroinflammation, and you need an ALT 2 times the upper limit of normal. So in fact, very few patients that we see of chronic hepatitis will meet those clinical criteria. So for all intents and purposes, pegylated interferon is not really appropriate for the patients that we actually see. I think there's another question. For glomerulonephritis, possibly treat with TDF may be of benefit. So those are, I mean, that's an important, those extrahepatic manifestations, which just reminds me what I wanted to say. So in terms of the skin lesions, I've only really seen them in sort of teenagers, young adults who get acute hepatitis B. I haven't really seen them, the skin lesions in patients, in adults with chronic hepatitis B. What obviously one does see is the renal involvement, and there is a small risk of lymphoma, but not nearly to the same extent with chronic hepatitis C. Now, one of the problems is that obviously you can't use pegylated interferon because they're most of them immune modulated. But unfortunately, with the renal involvement, actually switching off DNA replication doesn't necessarily equate to improving the renal outcomes. So as opposed to mixed cryoglobulinemia with hepatitis C, in fact, it's not normally as responsive, and it's probably thought because it's actually a surface antigen, surface antibody immune complex disease rather than the DNA level that's actually driving the disease. So unfortunately obviously you must treat it, but it doesn't necessarily equate that you're going to see improvement in the GN. My concern of possibly of test and treat, since the stoppage of the consolidation is even concerned, why not shift to test and treat? Okay, so that's a big, that's a big debate globally. Do you just test and treat? I think if we had curative therapy, that wouldn't be a problem at all. I mean, obviously, so if you look at when we started hepatitis C, there were all these criteria that you had to meet in order to get DAA therapy. The cost of DAA therapy went right down. Cure, 90% cure, 8 to 12 weeks of treatment. It's a no-brainer. You test and treat. For hepatitis B, it is slightly different. In that it is lifelong therapy. We know that patients are non-adherent, and there is a risk of actually having flares when you stop and decompensating. So, and then if you think about it, the access to tenofovir, even here in South Africa, there's poor access to it. So if you think about a continent where you have 82 million, all of whom having to be on treatment, I actually don't think it's going to be a feasible when it's lifelong therapy. But there's certainly some people believe in test and treat, but remember, if you are testing and treating, that doesn't mean to say these patients don't remain in care and in terms of follow-up. Any other, anything else? So I think just the other thing is that I think when you're starting patients on hepatitis B, there's this great sort of tendency to try and reassure, particularly these often young patients, to reassure them that, there's not lifelong therapy, you potentially be able to come off. I think that's the wrong message to be sending. I think you need to send a message, this is lifelong therapy. If you think about it, most of our patients have acquired it in childhood, okay? The treatment that we have at the moment is not curative. Majority of patients who are e antigen positive will not lose their e antigen, and those who are e antigen negative, surface antigen positive, will definitely not lose their surface antigen. So once again, if you stop therapy, you really need to follow these patients up very, very carefully. So every 3 months that first year, then every 4 months, then every 6 months. So personally, I don't think it's something that we should be looking at stopping treatment. It's a different matter if you acquire it in adulthood, you become chronic, you get onto treatment quite quickly. Those are patients that you potentially might be able to stop. But in reality, our patients, If you stop them, they're going to flare. And if you miss that flare, they can actually die. So I wouldn't be stopping treatment. Is there, okay, so is an indication for testing triple cDNA to determine cure. So the surface antigen concentration is a surrogate marker for the triple cDNA, and there are certain labs that can measure it. In terms of the triple cDNA, it's actually very difficult to measure, and it's still very experimental to measure it. There is another marker, the pre-core RNA, which also is probably a better marker of the triple cDNA, and also is a marker which actually potentially determines your risk of HCC. So those are markers that are being looked at in terms of actually monitoring more carefully. Any other questions? We're well over 20 minutes over, so I think we should let you go. So isn't it a fantastic presentation? Really, it's a lot of work to cover, but I think, you know, you don't have to be a hepatologist to really understand that hepatitis B is going to be core to your work. The prevalence here ranges between 3 and 25%. If you don't look for it, you're going to miss it. And if you are reliant on picking up symptoms or signs of chronic liver disease, you definitely will miss it. So thank you everybody for coming on. Thank you to Project ECHO from University of New Mexico, and particularly ECHO India for the support. And once again, thank you to Karen and Cheryl for their ongoing support in actually keeping us on time, sending out all the invites. So thanks everyone very much. And our next presentation is going to be in 2 weeks' time, chronic hepatitis C, and Prof. Sonrov will be the facilitator there. So well done, everyone. I hope it's a good start to your year and your introduction to hepatology. Bye.